Syntax 3 is a crazy idea. Syntax 3 is the concept of randomizing the heart team. So imagine that you have one patient, and this patient will be judged by two heart teams in the same hospital. One heart team will have only cine angiography, and the other heart team will have multi-slide CT scan and FFR CT. And both heart teams, one with the cine angiography and the other with the multi-slide CT scan, has to build up the syntax score anatomic, put the comorbidity with the anatomy, also combine the function and say that patient has to undergo PCI, or that patient has to undergo bypass surgery alone, or that patient is equipoise versus PCI and bypass surgery. And that's very clearly indicated by the syntax score 2 and 3 because it is based on the mortality at 4 years. So that was the first thing, the decision on the method of revascularization. And the second was about the planning. Tell me where you're going to put your bypass and tell me what you're going to do your stent. And the whole trial was about the concordance of opinion between the two heart teams. And of course, is the opinion of the multi-slide CT scan was concordant with the opinion of the cine angiography, then there is a message that maybe we can bypass in the future the cine angiography and go immediately from the multi-slide CT scan to the treatment, which is an easy thing for us interventional cardiologists. Having a multi-slide CT scan the day before is a bonus. I mean, you know what to do, you know the complexity, you have seen the calcium. For the surgeon, it's a black box. But we have interviewed them, we have done a survey where we showed them 1 year later the multi-slide CT scan of the study and say, would you be willing to operate that patient only with the multi-slide CT scan? And the concordance of the agreement of the feasibility was 83%. So that's the next step, is to ask the surgeon to operate only on the base of multi-slide CT scan. And that will be a revolution. That's also the title of the trial, Revolution Cabbage. It will be feasibility and safety, because we are going to control their bypass 1 month later. We cannot afford to have. Feasibility, they will be free at any time to say, sorry, I want to see the cine film. That will be the feasibility. If 25% of the people said, we want to see the film, the feasibility will be 75. The safety will be, okay, the bypass is on the right spot and is correctly implanted. No, I think the agreement between the two decisions, the agreement about the planning, it's very interesting that the elements of the discordance is the human being, the surgeon in the operating room, who said, I'm going to do this and do something differently. So there is a human factor there that you cannot correct, but that's not part of the science. That's basically the psychology of the individual on that day. And that trial is, of course, opening the Pandora box, because if it's confirmed, if it is doable, as I said, for us, it is a bonus. The real challenge is for the surgeon, but what can happen, and that was the question coming from the audience in the main arena, but also in the second presentation, is who is going to be the gatekeeper? And that can be a major change. If the radiologists get awake, they could become the gatekeeper. But the history has shown us many, many times that's the cardiologist, which is a kind of velociraptor, you know. He will take the multi-slide CT scan, create his own unit of multi-slide CT scan. And some of them now coming from Israel and working with GE are really small and has reduced the price. So you start to hear cardiologists saying, together with the radiologists, I will integrate fully the multi-slide CT scan in the cardiological unit. The next Syntax 3 program, there is two things. What I said, we will do 100 bypass surgery based on multi-slice CT scan alone. That's certainly something we are going to do. If we pass that stage, then we will make the major trial, which is to take everybody get a multi-slice CT scan. You take the decision PCI cabbage, and you go to the operative room of the interventional suite only with that document. You know, these days with the structural heart, you cannot talk about the cath lab diagnose. It has to be an interventional suite, and you have to use other modality to prepare your intervention. That's the key word.